I think I'll probably run right through until the end instead of giving a break, unless people get very restless. And then there'll be about a 5-minute break at most at about 4:15, okay, to sort of stretch your legs. You will get, hopefully, I have a presentation I'll give you today, and then there's a supplement with some more pictures and grids that will also be available for you that I obviously had no time to put on. Okay, my name is Dr. Suzanne Graham. I am a pathologist who has been in Lubbock, Texas for about 23 years. I graduated from Duke University Medical School many years ago, 1975. Did some fellowships and eventually went to Lubbock in 1987, where I've been since. I've done a lot of student teaching, and organization and administration, and student teaching is what I like to do the most. And so I'm very privileged to have been asked last time and this time to come to Chiang Mai, because we deal often with some very talented Thai medical students who come to train with us, and it's been a pleasure to work with you all. All right. We'll have some questions as we go along, and we'll break maybe at about 4:15 just to stretch our legs and then come back. Importantly, about pathology, just as we were just talking about infectious disease, pathology you're going to talk about is not the study of a slide, it's the study of disease. So it really crosses over everything you'll be talking about. All right, so pathology will factor into it, and I'm just going to talk about the high points of the things that will factor into both USMLE 1, 2, and 3, the kinds of pathology that you need to know based on my experience in the fact that, for instance, in Part 1, we have a lot of clinical scenarios, but what they're really asking you, they'll give you a classical clinical scenario, and they want you to go back and dig out the anatomy and the biochemistry and the stuff you forgot from first year. Okay, so as you study for these things, whether you're studying for Part 1, 2, or 3, remember always to go dig out the other things that you've forgotten, because you will forget them. You will forget everything you know, everything you as talked about today, probably maybe tomorrow or the next day. Why? Because you can't possibly remember it all until you use it. All right? So just remember just to repeat it as much as possible, and eventually it will stick. And for those of you who are just too chicken to use the audience response system, only 40 of you are doing it, and there's somebody who is punching E even when there's not a choice. This is anonymous, so go for it, okay? So I'm going to give you some questions as we go along, but I want to give you the high points of various areas, about areas that I think that they can ask you questions on, okay? So we'll be asking some questions in between. Please do use the audience response system. I like, in order to remember things, I do not have a photographic memory. So in order to, when I have a list of diseases that I need to remember, I put them in a grid. I list down the diseases, and then I say, what do I need to know about them? What age do they affect? What system do they affect? What's the classic thing that makes this disease different than something else? So that's a technique I'll show you here. If you like it, you can use it. Everybody is going to have a different way of remembering things, but that's the way I remember. I have grids from medical school that I still use because they still make sense. The molecular biology has changed, but the basic stuff will be the same. Brainstorming is really important, and that means that every time you get a question, you think, why did they ask me that question? How else could they have asked that question? And we'll practice that a little bit today. But the important thing, do not look at a review book and assume that if you memorize that review book, those questions will be on the USMLE. That's not true. You'll also discover that if you use one series, let's say in pathology, you look at one first aid, and then you look at the checkerboard series or the BRS series, you'll discover they pretty much cover the same thing in slightly different ways, just depending on who is writing them, but they're all covering the same thing, and that's true in every single area. So pick one you like and go with it. And then, you can get your friends will add things in that's not quite covered as well in that. But don't try to use them all, because you can't possibly do that. All right. And again, just imagine anything some really dirty, rotten person writing a question at the last minute could ask you. Or a biochemist is going to sneak something in, okay? Play a game and make it fun. Okay. There are lots of things online, and it's so much better even than it was a few years ago. There are lots of review books. There's about 400 for all the medical specialties. There's dozens for pathology. Some of them are available online. A lot of it's free, all right? And even if it's not the most recent edition, very much of it's going to be true and good. For instance, Robbins, which is the big pathology book in the United States, is an 8th edition. And the molecular pathology is very different in it. But if you were to get a 6th or 7th edition, much of it would still be good. All right? And a lot of that's available online, and I'm sure you have friends with those. Rubens is another one. But there's a lot of stuff available online without buying those books at all. On the web path, some of you have visual memories. You can remember a picture of anything. Others of you don't. You learn differently. All right? WebPath, which is available and it's mirrored in many sites throughout the world, has excellent pictures, and they go ahead and ask simple questions. They take you to CT scans and then come back to the pathology. They have questions online, and there's lots of places, and that's not unique. There are several places like that, but that's well established. That's originally from the University of Utah, which started the whole internet stuff. So there's a lot of place online that you can go and get something to study. So let's talk about general pathology. This is the part that's usually the boring part for you all, because it's not a disease. It's not a 55-year-old woman coming in with an elephant sitting on her chest that you say, that's a heart attack. It's the inflammation and repair stuff you learn earlier, and my medical students fall asleep through it. But let's see how, I'm going to go through some of the major principles very briefly, and then we'll see how it practices out in some of the organ systems. Remember that all of pathology is about the injury, which is an infinite thing. It's the sword hitting you on the head. It's the bug attacking you. All right? It's the autoimmune disease. It's the atherosclerosis. Whatever the injury is, it's a fight between how serious it is and how you can respond to it. So you'll learn a lot in infectious disease. You'll learn a lot about the bugs that can injure you. In orthopedics, you learn about the trauma that can injure you. In pathology and other diseases, you're going to talk about adaptive immunity, acquired immunity, or innate immunity, and all kinds of things that you can do to fight that. The rest of your time, you're going to be learning about what makes a healthy individual. And anybody who isn't healthy for any reason, bad atherosclerosis, diabetes, etc., is not a good, healthy host. So they have trouble fighting those diseases. So when you're looking at a question, always, is this a healthy host? If they're immunocompromised in any way, then they're going to be more subject to certain diseases that you've already talked about today. How can you respond to injury? You can adapt to it. You can make more cells or regenerate cells that are injured. But inevitably, okay, you're going to end up with some death, either one cell at a time, apoptosis, or lots of cells, necrosis, because you just can't adapt anymore. How are you going to respond to those mechanisms? Inflammation and repair. We'll talk about some of the cell types. We'll talk about the difference between acute and chronic inflammation, hypersensitivity, autoimmunity. That's all in the next 10 minutes, right? Okay. How is necrosis, inflammation, and repair manifested clinically? All right. Rubor, pain, fever, all of those things. So a lot of those things are going to come out clinically for you to decide. All right. And when we look at neoplasia, it's a loss of control, again, with another area of injury. We'll get to neoplasia. But it's really another injury that you're just responding to. So what happens? This is really complex. So we're going to go through this briefly, but this is everything that can go wrong for you in one slide here. Let's see here. We have an injury. That's anything, an infinity amount of injury. An oncogene, all right, producing cancer, trauma, chopping your head off, okay, autoimmune disease. Anything that can hurt you is an injury. And you can adapt. You can make more cells, hyperplasia. You can make bigger cells, especially in places that can't regenerate. What are some of the organs that can't regenerate when they're hurt? Give me one. Somebody. The brain. What else? Muscle, skeletal muscle. Smooth muscle can a bit. It can make hyperplasia, but not skeletal muscle. And the other big guy that pumps all the time? Your heart, okay? So some can respond very well. If you get a little ulcer in your stomach in 3 days, it's healing itself over. So the stomach is great to regenerate. Your heart isn't. All right, you can atrophy. If you don't use something, all right, it's going to atrophy. And everybody knows who's broken a leg, all of a sudden the muscles in and around that leg will just disappear in 2 weeks. All right, and you'll have to rebuild them up again. So atrophy is a response to withdrawal of some kind of stimulus. And then metaplasia is a response to injury that you have one kind of cell becoming another mature cell. Perfectly normal. All right, it's not premalignant. But it makes, if it doesn't turn around because the injury is taken away, it means that all of a sudden you can end up with something going on later on in that area of metaplasia. We'll talk about a few areas. So eventually those adaptations fail and you end up dying. The cell dies. And if it dies one cell at a time, little bits, not stirring up much of anything, it's apoptosis. When it stirs up the entire inflammatory cascade, it's called necrosis. The response is either acute or chronic. And acute, that simply means it happens right now. And everybody knows that acute, lots of neutrophils, usually PMNs, polymorphonucleosides, so I'll use that again. All right, that's usually very common, but at least it also means leaky vessels. So you end up with something red around the area, you end up with congestion, you end up with edema. If it's leaky vessels inside your lung, you'll end up with pulmonary edema. So you can imagine that you could take acute inflammation and give you any kind of itis and inflammation throughout your body. So you may not even think about what's happening, but that's what's happening. All kinds of, the cytokine symphony is going crazy, stimulating things and producing that problem locally. Now if the injury goes away, if whatever has injured you, the bug has gotten really quickly, or somebody has stabbed you with a needle and you don't have any more problem, you're going to resolve that very quickly and regenerate. But let's say you have continuing injury. You're continuing to injure your vessels with atherosclerosis. You're continually out of whack with your diabetes, all right? All kinds of autoimmunity is constant low-grade injury. You're going to end up with a pattern of chronicity that's going to give you a lot of things that you've heard of before. In some cases, you're going to have generalized inflammation, lots of chronic inflammatory cells. Can somebody give me a chronic inflammatory cell? One of the ones that we talk about, the hematopoietic cells that are in chronic inflammation. The names of some of them? Macrophages, right, biggie. All right, processes antigens, macrophages are a biggie. Another one. And eosinophil is technically, that's right, it is a chronic part. It's part of some acute things too. It's a sort of a sneaky little bugger, but it's between the two of them. But the other big one with the macrophage is lymphocytes, exactly. So those make up what's mostly chronic. Now something that we'll talk about that's very confusing, and we won't talk much more about it today, is that sometimes you'll have an injury, an injurious agent that you just can't quite eat up, fight up, get rid of, like TB, like a foreign body, and you'll surround it by something with lots of macrophages, some lymphocytes. You'll call that a granuloma, and you've heard about that, right? Okay? A granuloma is very characteristic. You'll get a picture on an exam. There are pictures in the supplement. People always get confused. It is not related to granulation tissue, okay? Outside of granulomas, which again is TB, foreign bodies, things, some funguses, things that you eat and can't get rid of, when you try to heal a large injury area that you can't regenerate, then you're going to form scar. Then you bring in the vessels from around the area, all right, bring in all kinds of macrophages and things that clean up the area, bringing in oxygen, making new blood vessels, bringing in fibroblasts. That's granulation tissue. It is not a granuloma, despite the names. All right, it's very confusing. And so when you're reading a question, make sure you get that straight, because usually they'll be asking about a granuloma, actually. All right. Apoptosis. It's initiated normally and abnormally. All right? And you've read a lot more about it. It's a lot in molecular pathology, and you're going to be talking about molecular biology, I think tomorrow, actually, because we're a little bit out of sequence. So you'll be talking a lot about what goes on with apoptosis. The result, however, is that there are only a few cells dead. And the classic thing is when somebody has viral hepatitis, then you just kill off one cell at a time with a macrophage and a lymphocyte hanging out. Doesn't engender much of anything else. Doesn't engender the fever, the normal vascular changes that you see in necrosis, okay? It can also be seen normally when you withdraw hormones, all right? As you get older, men will have testicular atrophy, women will have ovarian atrophy, just when you withdraw hormonal changes. So it can be abnormal or normal. Here's a classic example, and do I have a pointer on this? Let's see here. Guys, yeah, I think I forgot where you put it here. Hmm? Which one? Oh, that one, we'll do it. Oh, that'll do it. Okay, all right. This guy, all right. This is a very high power view. It's hard to know what it is, but it is liver, all right. And these are normal nuclei with some cytoplasm around it. This is what used to be a cell with a lymphocyte hanging out. This is a bit of apoptosis, classic for viral hepatitis. Now, apoptosis you'll hear a lot about. It's very popular. It's very important. You know everything you want to know about apoptosis. Why? Because too little apoptosis, i.e. not getting rid of cells you don't need anymore, which is the normal part of it, can produce cancer, especially related to p53 defects. This is very complex, and I won't go into much more of it here. All right? And also in some hormone-dependent areas. Autoimmune diseases probably also have the same problem. So if there's too little apoptosis, you get too many cells proliferating in a bad way, all right? Too much apoptosis, excess cell death, can be seen in specific neurodegenerative diseases. Now, this is relatively unusual. I never see spinal muscular atrophy, so it's relatively unusual. But this would be an example if somebody asked you a question on this. It wouldn't be because they really expected you to ever see spinal muscular atrophy, but because they wanted you to know something about apoptosis. So sometimes you'll get a question about a rare tropical disease, what we call a rare tropical disease, a very unusual thing, because they want to ask you a question about something else, like biochemistry, like in this case apoptosis, or maybe the mechanism of apoptosis, to get you back to basic sciences. And you actually, after a while as a clinician, you will forget the basic science underlying what you do every day. So you have to dredge it out. There's always Google now, but thank heavens. All right. But, all right, ischemic injury. Also, when we talk about heart attacks, you think of heart attacks as being masses of necrosis. And that's usually what it is, the classic symptoms and the pictures that we'll show. But somebody has a little bit of injury, not a lot of the usual stuff, but a little bit one at a time, maybe a penetrating vessel in their heart that's not working well, all right? Or just a little bit of ischemia for a small period of time. We'll pick off one cell at a time. And you won't even notice it's gone, okay? But I can see it on histology, because it'll be one cell at a time. So sometimes something that normally produces a lot of necrosis in a mild way can produce apoptosis too. And then viral infections very characteristically have apoptosis. Now this is versus necrosis. This is gangrene. Oops, how about going backwards? This is gangrene. If it's mostly ischemic necrosis, coagulative necrosis, it's going to be dark and black. And I think all of you have probably seen that if you've had any patient contact at all. All right? And this can happen for a variety of reasons. In the United States, it's primarily from type 2 diabetes. You are mostly slender people. You probably have a much lower incidence of type 2 diabetes. I hope so. All right? But this is dry gangrene. Now, if you end up with secondary infection, you'll end up with wet gangrene. As you can see, this is a huge amount of inflammation, obvious both clinically, and this would produce systemic as well as localized symptoms. This is necrosis. So acute inflammation, vascular changes, lots of neutrophils. The macrophages will still be there pretty quickly because they're going to clean things up. But the primary thing early on is that neutrophil. Lots of cytokines, interferons, okay, complex chemical chemistries, all right, including all kinds of things going on that you'll be talking more about tomorrow. All right, now chronic inflammation, it's acute inflammation that persists, and it can be little or a lot, all right? And so it's both time and repeated injury. So it has a time component, but also repeated injury component. Macrophages are working together with the T cells. Again, the interferons, endotoxins, complex interactions that I'm not going to go into now, and that are ill understood. And the good things about this, if something is really not well understood, and maybe 5 years from now it will be, so you have to be careful as things change every year, is if it's an ill understood what happens, they can't ask you a question about it. So the longer we talk, the less we know. So be aware of what your professors are trying to tell you is what everybody accepts, so somebody can ask you a question on. All right? So complex interactions, and then that local variant, when you have delayed granuloma, which is again a characteristic of delayed hypersensitivity. We'll get back to that in a minute. And the main reason I'll do it later again, so you'll see these things again and again and again, which means it will cement it in your brain even if you don't think so right now. Now, how do you heal things? You heal them with regeneration or scar tissue. And scar tissue is granulation tissue or fibrovascular granulation tissue. We talked about the fact that some places some cells can renew themselves, some cases can't. For instance, your stomach can, your skin can, your heart can't. And some, like your liver, doesn't normally regenerate itself well, all right? But when stimulated, it can, all right? And this is changing, or our idea about this is changing. For instance, the stem cell proliferation, which was largely engendered in the United States because there was a lack of stem cells from embryonic terms. So people just did a lot more research on where stem cells come from in adults. And it turns out things hang out around the portal tracts, for instance, in the liver. So it's not cells degenerating or regenerating, it's new stem cells being stimulated into making new liver cells. So it's a very exciting area for those of you who are interested in research. Now, granulation tissue needs angiogenesis, which again is complex, VEGF, vascular epithelial growth factor endothelial growth factor is very important. You've got to know something about that. And this would go back to a Notch pathway. What do I know about the Notch pathway? What I learned on Google last night, okay? The Notch pathway is a way of intercellular connections during embryogenesis primarily to turn off an area next door that should be something else. It's complex, but it's a biochemistry factor that somebody might bring in when they talked about scar forming somewhere, start to ask you a biochemistry question about the biochemistry that you will learn from somebody else besides me. But there's so much interaction going on. Just imagine you sit and brainstorm about what could they possibly ask me about that. And then you have your friends help you do that. All right. And then the architecture, how good is this regenerated? Well, it depends. For instance, the liver can regenerate very well as long as the basic stroma upon which those liver cells can regenerate is still there. But if you completely wipe it out with a lot of necrosis and severe injury, it's going to have to form a scar because it just can't regenerate. All right. So much, you'll see classic patterns, but there'll be wide varieties in real life. How much do you make that scar? Well, you make lots of collagen with myofibroblasts. And again, cytokines, tumor necrosis factor, TGF, Growth factors, very important. TGF-beta is a biggie here, all right? And again, proliferation by growth factors, control by growth factors, sometimes they go out of control. Now, when you're talking about inflammation, what cells do you need to recognize? They often have pictures of hematopoietic cells on the boards. So this is a nice picture of several. Do make sure you can tell. A, neutrophil, segmented neutrophil. This is probably a segmented neutrophil, although it looks like it's got toxic granulations. All right, here is a lymphocyte, which often has even less cytoplasm than this, a mononuclear cell. Here is a monocyte or a macrophage. A monocyte is one that's floating in your blood. A macrophage is in tissue, same cell. And it often has a kidney bean or an irregular sort of brighter nuclei or larger nuclei and much more cytoplasm. All right, but in tissue, if they show you a picture in tissue, you can't tell a lymphocyte from a macrophage many times, so you end up calling them mononuclear cells, all right? So, but because they always hang out together. Now, we can't do special stains, but they shouldn't ask you about questions like that, all right? And then here is a more immature neutrophil. It's called a band. It's an unsegmented neutrophil. And here's a basophil floating around, and you can judge the size, because how big is a red cell? About how many microns? 8 to 10, somewhere in there. So you can use that to judge the others. And so they love to ask you these. They're very simple usually. It's pretty a straightforward question. All right, immunity, huge amounts. Immunology is huge and it's growing every day, and these things may change over time, so you'll have to keep up with it. But there's two basic kinds, innate and adaptive. Innate or basic, it's when back in evolution you developed the ability to fight off bugs. And the big parts are epithelium, macrophages along your epithelium, your skin, your GI tract, ways to keep those bugs out. Natural killer cells are big here. All right, very complicated system, and again, only now being really worked out. The toll-like receptors, NF, kappa B is very important in here. Adaptive. Macrophages and lymphocytes, again, working together to grab antigens, present it to lymphocytes, and remember it when it comes back. That's all about adaptation. That's fairly straightforward. So adaptive immunity is really terribly complex, all right? And this is my version of making it a little clearer, and you'll need to get more details on your own, all right? T cells and B cells work together, but cell-mediated immunity is T cell-centered. Again, recognizing peptide antigens. Antigens are prostate differently by different major histocompatibility complex areas depending on where they are in the cell. So MH1s are in the cytoplasm and MH2s are in vesicles in the cytoplasm. All right? And that helps you remember why some things are adapted differently than others. All right. CD8 cells, which are cytotoxic T cells, recognize the MHC1 antigen and are usually used against viral infections. Yeah, let's see. Yeah, there we go. CD4, which you spent a lot of time learning about with HIV infections, for instance, again, are related to MHC2 molecules. And they can work in a variety of ways. When they get together with helper type 1 cells, they work with interleukin 12, make interleukin 2, and are very much related to the way we work with TB. We'll talk about that more in just a minute. They help to opsonize other things. This is the area of delayed hypersensitivity. When you're dealing with Th2, then you're dealing with eosinophils and a different group of interleukins, all right? Classic asthma, great questions. You can ask about asthma and TB and bring all of this back at the basic science level. And again, the subtleties of this will change. So usually, at least now, there's not a whole lot of molecular factors that you have to remember because, except for the big main ones. Why? Because only in the last 5 or 10 years have they really been standardized. Then you get over to the humoral immunity, which is, again, terribly complex, and deals with protein and non-protein antigens, often related to autoimmune diseases. And then dendritic cells get in here, and this is another area that's changing rapidly. These are the antigen presenters. Up the Langerhans cells up in the epidermis, the dendritic cells and lymphoid follicles. So lots of things are changing in immunity. So you'll need to keep up with this to find out what the truth is for the exam whenever you decide to take it, whether it be here or in Thailand. I mean, in Thailand or in the United States. Now, hypersensitivity is the stuff that's listed out and talked about in Robbins, and this brings all of this back. Type 1 hypersensitivity is IgE related. Again, major histocompatibility 2, Th2 related system. Again, CD4 system. All hypersensitivity, asthma, anaphylaxis. Hypersensitivity 2 is related to transfusion reactions, autoimmune hemolytic anemias, Goodpasture syndrome classically, because this is an antibody to a basement membrane or matrix. So there's all kinds of things that type 2, this is a very classic question, a characteristic area of interest when it comes to exam questions. Type 3 is antigen-antibody complexes, either usually IgG or IgM when they're complement fixing, sometimes IgA by alternate pathways. Serum sickness, SLE, systemic lupus erythematosus, and some of the glomerulonephritises. All right. And again, type 4 cell-mediated hypersensitivity, again, Th1, TB primarily, and then we get down to viruses. So we're repeating what we just said in a different way. So you're going to learn this in several different areas. Just put it together and realize people are talking about the same thing. Autoimmune diseases are favorite areas to ask questions about, and specifically about SLE. Know everything you need to know about systemic lupus erythematosus. All right, anything that can go wrong does. It was the prototype for autoimmune diseases many years ago. It and many of the other autoimmune diseases are characteristically associated with autoantibodies, whether they're causative or epiphenomenon, i.e. just go along with the disease. People still talk about it, but we're not sure. The idea is to know what they are. Make yourself a grid of the autoantibodies most characteristic of those autoimmune diseases. For instance, double-stranded DNA is associated with SLE. Rheumatoid arthritis. RA factor is an IgM autoantibody to the FC factor of IgG. They might ask you to give you a classic rheumatoid arthritis question, which is really fairly straightforward, and then ask you this and not about how to treat the rheumatoid arthritis. Others, there are lots. Sjogren's, scleroderma, PSS, progressive systemic sclerosis, people will often use that, is very characteristic and has some interesting features. In the GI area, people love, it's a very common disease in Northern Europe and in many places in the United States, is gluten-sensitive enteropathy or non-tropical sprue. It's associated with diarrhea, but more specifically, it's associated with some other things. And people love complex diseases. So they can give you a clinical history that says this person has this, this, and this. And by the end of that history, you should know from the clinical scenario, okay, what the answer is. All right? Because they've given you enough features to say it only could be this. And for instance, this person has, if this person with diarrhea and problems with absorption ends up with dermatitis herpetiformis, you don't even have to know what that is or how to picture it, but you should be able to know that, that makes me think of gluten-sensitive enteropathy, or GSE. Everybody abbreviates everything. And I know that must be much harder when you're trying to do it in English. They also have a higher risk of some kinds of cancer. Now, genetics. I am not the one to teach you genetics, all right? But the one thing about genetics is there are cancer mutations that you need to know about, and there are classic ones that I've given you some grids for, and we'll hit some of them today. And then there are the classic chromosome abnormalities that people can give you clinical scenarios are. There are usually a few of them. They're usually relatively straightforward. All right? Trisomy 12, 13, and 18 and the congenital heart defects are things you need to know. You need to know about Klinefelter's versus Turner syndrome. And you ought to be able to work out, and I think you probably have already, did you take genetics last year? Have you taken genetics? Somebody? Genetics? Have you taken genetics and learned about autosomal dominant? Yes, you know about those, okay? Then there are characteristic diseases that are autosomal dominant and recessive, and you ought to be able to work out a fairly simple tree of family, because they will ask you about some of the classic ones. All right. Mutations can occur at the time of DNA synthesis and or regeneration, mitosis, meiosis, but you can also have epigenetic alterations, which are getting very hot, and I won't spend much more about that right now because it's just, and I'm not even sure if there are questions on it. But when you talk about methylation problems, a lot of this has to do with what happens with cancers, why people develop cancers over time. So there's a lot more about epigenetic changes that you'll need to know about in the next few years. Something that's very commonly asked is about the triple nucleotide repeats for specifically Huntington's disease, and about something called anticipation. It means that these end up getting longer and longer, and the disease gets worse and worse in a specific family over time. All right? There's always a question about Huntington's, and you can ask it in an infinity of ways. You can give the clinical information. I'll show you a picture of it later. You could ask about the genetics of it, and it all relates down to this CAG repeat. Also, one of the most common causes of, or the second most common cause of mental retardation is Fragile X syndrome, which is a CGG repeat. So, classic little pieces of information that help you put together clinical scenarios. These are a list for your viewing pleasure later about the most common autosomal dominant, recessive, and X-linked diseases. All right? And they're relatively straightforward. You'll see them all. Again, they might ask you about them, and you need to know everything you need to know about these diseases. This is pathology in a whiz here. All right. Cancer. It's important to know the difference between staging and grading. Everybody confuses it. In the United States, every tumor that is done has to be staged, which means, and the AJCC, what's down at the bottom, is the American Joint Commission for Cancer, AJCC. Anybody who runs a cancer institute has to have a very formal, rigid staging system. So every person who's being diagnosed and treated for cancer is staged. Every carcinoma, except very rare ones, are covered by that. And they're staged by the size or the type of the tumor, that's a T, whether it goes to nodes. If you remember, carcinomas go primarily to lymph nodes, right? So you have to look at whether there's nodes, a few or more, depends on where you are. You don't have to know the specifics of carcinoma of the breast, of the colon, of this. Nobody knows that. We look it up in a book. But you have to know that basic principle, and then whether it's metastasized at all. And you add to that together what your T is, and what your N is, and what your M is, and you end up with the stage, Roman numeral 1 through Roman numeral 4. And so you need to have that information, or at least know that you have to gather that information for the staging. Grading has to do with what the tumor looks like. Does it look like the tissue that you're going to name it after? Does it really look like squamous cells? Is it even hard to tell it's malignant? You'll say it's a well-differentiated squamous cell carcinoma. If it's really hard to tell it's even squamous, you'll call it poorly differentiated, and in between you'll call it moderately differentiated. That's grading. So grading is important and it's helpful, but it's not as important as staging. Okay, because staging is everything in cancer. Now, it works very well with carcinomas. There is a system for sarcomas. It doesn't work as well, and we're not going to talk any more about that today. And most places in the world now use the WHO system for lymphomas and leukemias. So we do stage all of them in different ways. And as you go through, you'll hear the highlights of those, and that'll adjust over time. The associations, you'll need to know generally. Why? Because some of these diseases have prior diseases or toxin associations that are very specific for that. Sometimes they have very specific genetic abnormalities. Paraneoplastic syndromes are often a hormone or hormone-like structure or a hormone-like substance secreted, or sometimes something secreted that's unknown by a tumor that produces a syndrome that doesn't present because of where the tumor is, or that you can see it, but because it's producing a substance. For instance, squamous cell carcinomas produce a hormone that looks like parathyroid hormone. So people present with hypercalcemia. Okay? So if you know those kinds of features about any given malignancy, you'll do fine. Now, oncogenes, the one good thing about oncogenes is there's lots of them, but they're only associated with very specific diseases, or some of them are associated with so many diseases. They'll never ask you a question. Why? Because it's not specific. Okay, but there are some, like the MYC oncogenes, neuroblastoma, NMYC, Burkitt's lymphoma, CMYC. I won't go through all of those, but as you learn them, they're key pieces of information because they're very specific for one or two diseases. Learn them, and you'll forget them. You'll learn them again, you'll forget them, but the third or fourth time that you see a patient with one of these or you've heard about it, you'll say, I remember that, and then you'll be fine for the exam. The one thing you need to know a lot about, especially in the United States, is HER2/neu. This has to do with breast cancer. You need to know everything there is to know about that. All right. Now, the tumor suppressor genes, there's lots of them. Again, BRCR1 and 2 related to breast cancer, and the APC beta-catenin pathway in colon cancer are the biggies that you need to know. There are others. This is sort of endless, isn't it, guys? And you're just so swamped right now. But specifically and very importantly in the lymphomas and in the diseases of the hematopoietic system, a lot of these are associated with specific translocations. And in some of the leukemias, it means they actually have a better prognosis. So you need to know these too. And this is way too big. Okay, so let's see if I can remember what it says at the bottom. 72-year-old man, we're going to do a case with an abnormal x-ray, followed by a biopsy. And he had a back pain for the last couple of years. What do you see on the x-ray? There's a hole right there. Okay? Well, I'm going to give you another picture, two more pictures. And so does that look like normal bone marrow? This is a biopsy of that hole. Does that look like that normal bone marrow? No. You may not know quite what it is because it's just sort of sheets of cells that all look alike. But do you recognize this guy? A plasma cell. Oh, very good. Okay. So if this is a plasma cell, then you should be able to answer this following question, which I think is linked up. Yes? We have we have hyponatremia and mediastinal mass, elevated T4 and thyroid nodule. What other significant findings we're looking at? Elevated hematocrit and RBC mass, elevated serum IgG and positive Bence-Jones protein, and then something else at the bottom that we can't see. And I think it's the wrong one, so why don't we go for it, and if anybody punches E, well, we'll know who it is. It's the person who's been doing it all along. Can we do it? Yeah, there we go. We have 15 seconds. So does this person have hypernatremia and mediastinal mass, elevated T4, elevated hematocrit, or elevated IgG? See, you knew it all, and only 39 of you did it. See, the rest of you knew it too, right? All right, so this is what? This is multiple myeloma, okay? Okay? Now, let me go back actually here. What is A? If this person, what hyponatremia and a mediastinal mass? Anybody?